internist here, and a lot's changed in the past couple of years, and I don't know all the residents. So, when I was an intern, and this is in 1983, I learned this pneumonic. It's called CRIPS. CBC, we take out indices, peripheral smear, platelets, and stools. And it was just a pneumonic, but God knows how many things could cause anemia. And this gives you a way to start out. Now, things are done a lot different now, I get it. And out of all of these, really, the most important thing in this pneumonic is indices, the eye. There are three major mechanisms of anemia: blood loss, marrow failure, hemolysis. Now, you have a combination. If you have enough blood loss, okay, you'll become iron deficient. That'll be marrow failure. If you have enough hemolysis, you'll become iron deficient and also folic acid deficient, and you'll have marrow failure. But you can basically group mechanistically every cause of anemia for one of these three things. So the MCV, like I said, this is the most important thing. Is it low? Is it high? Is it normal? So a low MCV, look at it like this, okay? Hemoglobin equals heme plus globin. Heme equals iron plus porphyrin plus globin. Okay, so if you have a low hemoglobin, low MCV, you're either iron deficient or you have iron deficient erythropoiesis, a globin chain problem like thalassemia, or theoretically, although not common, a porphyrin problem such as lead poisoning or sideroblastic anemia. Iron deficiency anemia. Okay, this we see a lot. Okay, the MCV is a late finding. Iron decreases before hemoglobin decreases. Okay, so initially these people may have a normal MCV, and your iron and iron stores will decrease before your hemoglobin decreases, and the hemoglobin will decrease before the MCV decreases. So most iron deficiency is not microcytic, it's normocytic. So you're going to get iron studies. So the most important study to get is ferritin. If you have a low ferritin, nothing else does this but iron deficiency. It's found in the liver, macrophages, and it's very specific. If it's low, you have your diagnosis, but it could miss many iron deficient patients. The cutoff's really 30. If it's under 30, there's a problem. Okay, then you have the iron and TIBC, and this can be very tricky. With this, if the saturation is less than 16 to 20% with a 5 to 9 hour fast, that's consistent with iron deficiency. Okay, and the TIBC is going to be high with iron deficiency, and it's going to be low with anemia chronic disease, and that's something that could get confused with iron deficiency. Both have low transferrin saturations. What are the symptoms of iron deficiency? Pica, paraphasia forms of pica, craving for ice. Often you can see a young woman with heavy menses, has a low hemoglobin, MCV, you have a craving for ice or anything cold. Yes. This has been associated with restless leg syndrome and also fatigue, and fatigue often independent of hemoglobin. Now, a lot of things could cause fatigue. If you diagnose iron deficiency, you need to find the cause. Number one, it could be a woman with extra weight heavily. But other than that, you need to think of GI losses. And the biggest thing you need to do is a colonoscopy. And you really need a complete GI evaluation. And endoscopy, and you want to check for celiac disease if you don't find the cause, and also Helicobacter, and that can cause iron deficiency independent of having an ulcer or bleeding ulcer. And in women, uterine fibroids with heavy bleeding could also do that. Okay, this is an important concept. You guys may or may not know about this. Iron-restricted erythropoiesis. Oral iron cannot get past the hepcidin block. This is anemia chronic disease. So you have some type of inflammation, produces IL-6, which produces hepcidin, and you can't mobilize iron from the macrophages and the reticular endothelial cells into the marrow. Okay, worst examples, dialysis patients. Now, IV iron, not an oral iron, could overcome this block. Okay, thalassemia. Where are you going to see this? So here you have an anemia, a low MCV, but the red count could be elevated. They produce a lot of small red cells, but a lot of them. To diagnose beta thal, you get a hemoglobin electrophoresis, and see an elevated hemoglobin A2 level. You see beta thal in people with Mediterranean ancestry, Middle Eastern, South Asian. Alpha thal, you can see in people who are African. I have African ancestry, Southeast Asian, and Middle East populations also. Often you can see an African American or a black patient who has a low MCV, their hemoglobin's normal or minimally low, and the red count's elevated. That's telling you that they probably have one of the variants of alpha thal, like alpha thal silent carrier trait. There's something called a Menser index, which is the MCV divided by the red count. It's less than 13, thalassemia greater than 13, iron deficiency. So if you're admitting you have a patient who's anemic with a low MCV, you're trying to figure out the cause. This is a tool that you can use. Sideroblastic anemia, you can't incorporate iron in the hemoglobin properly. And that's part of the myelodysplasia spectrum. But I'm not going into this. This is not common, okay? And they often, more often than not, their MCVs are not low. Anemia chronic disease, like I said, you can't mobilize iron from the reticular endothelial cells and incorporate it into the hemoglobin. It involves hepcidin. Normally, the MCV is usually normal. Let me say that. And if it's low, it's not very low. You're not going to have anemia chronic disease with an MCV in the 60s. But it's very important. If a patient has anemia chronic disease, they need a chronic disease. If they don't have chronic disease, you can't call this anemia chronic disease. So, someone's got infection, chronic inflammation, connective tissue disease, active malignancy, yes, that's anemia chronic disease. If they have renal insufficiency, that's part of the mechanism there. But you need a chronic disease. Okay, I'm gonna stop for a minute, take a pause. Anybody have any questions on these slides? Are these okay? No questions? Okay, so let's talk about a high MCV. So you have a patient who has a high MCV. Now that's the average cell count. The first thing you do is get a retic count. You don't really need to automatically go to B12 level, whatever, because if you have a lot of retics, okay, that's going to cause a high MCV. Now, if you have a high MCV and decreased retics, you think of megaloblastic anemias. B12 and folate deficiency. You guys need to know, folate deficiency is really rare unless someone's on like methotrexate, not taking Okay, but B12 deficiency, C. These patients have a high LDH because of intramedullary hemolysis. They have hypersegmented polys, macrovalocytes. They could have an elevated homocysteine. And with B12 deficiency, you see elevated MMA. Okay, other things that can do this, sometimes myelodysplasia, certain meds, hydrea, which their patients on that. AZT was the first antiretroviral therapy to treat HIV. That's not used anymore. Once in a while, hypothyroidism. And also alcohol use. Somebody, everything else is going on, the MCV is high. You can order a PEP level, phosphatidylethanol, it's elevated. The patient is drinking too much alcohol. Moving on. If their count's high, either have hemolysis or anemia. So if you're evaluating someone for hemolytic anemia, is it congenital or is it acquired? And if it's acquired, is it immune or non-immune? Okay, could everyone see this slide? Okay, I'm not gonna read all these things. The red cell membrane defects you learned about in medical school, you may or may not see them. G6PD deficiencies are real thing. 12% of American black males are heterozygous for this. You have to think about that, especially meds that can precipitate anemia. The hemoglobinopathy is really sickle cell, and most of the patients come with this diagnosis. You're not going to be diagnosing it in the hospital. Okay, now what about acquired? Acquired hemolytic anemia. The hallmark's the spherocyte. I'm going to show you a picture of it later on. And the diagnostic test is really the DAT, the direct antiglobulin test, or it used to be called the direct Coombs test. And you know, the most common cause is idiopathic warm agglutinin hemolytic anemia, where you have IgG autoantibodies to the red cells. You can see acquired warm agglutinin hemolytic anemia with lymphoproliferative disorders and connective tissue diseases like lupus. An important point I want to make here, and I made this a morning report, it used to be part of the evaluation when you're admitting the patient, that the house staff would look at the profile smear, and if you're presenting them the morning report, you know, you would be responsible for that. And you can't do that now. It just doesn't exist. You're too busy. You know, the people in the ER admitting the patient, they're not going up into the hospital. Then they're being handed off to another resident who's on the floors. Next day, somebody else is going to take care of them. But really, how you learn about this is looking at their profile smears. It's just that the way things are have changed a little. Okay, idiopathic cold agglutinin disease, these are monoclonal IgM antibodies, and they bind to red cells at lower temperature. They could activate hemolysis and cause intravascular hemolysis. To be idiopathic, theoretically, you can see with mycoplasma, Epstein-Barr virus, or clonal lymphoproliferative diseases. I have a patient right now who's just talking to somebody about him, and he has acquired cold agglutinin disease. Not common, but it exists, and you need to know about it. Okay, medications could cause immune-mediated hemolytic anemia, and there's a long list and different mechanisms, and over 150 drugs are reported. Ceftriaxone and piperacillin are the most common. Other things you can think of, you know, paroxysmal cold hemoglobinuria, which is part of, I think, secondary syphilis. You're not going to see this. Paroxysmal nocturnal hemoglobinuria, these patients clot. They don't bleed. You know, unusual, you could see this. An acute hemolytic transfusion reaction, you'll see that you're transfusing blood and something's happening. non-immune mediated acquired hemolytic anemias. These are the MAHAs, okay? Microangiopathic or macroangiopathic hemolytic anemia. The hallmark of this is the schistocyte. And if you're really evaluating somebody for this is an emergency. So if you're not going to look at the red cell, okay, you need to either call the lab and go over it with the technician, or if there's any concern, you need to call hematology on call. Now, you can see it with heart valve hemolysis. These are with older valves, more aortic valves. Don't see that much. A hypertensive emergency, theoretically, something called March hemoglobinuria, which I'm not going to talk about. Theoretically, you can see it with a scleroderma renal crisis. And obviously, a patient will have a history of scleroderma. Okay, the ones you have to think of, TTP you have to think of, because we get a few cases of this year. And there are 5 components. You don't need all of them, but you have to have a microangiopathic hemolytic anemia. And you'll see schistocytes and thrombocytopenia. And there's often renal involvement. Even if the creatinine's normal, you get an abnormal urinalysis. Also, CNS involvement in fever. And the mechanism is decreased ADAMTS13, which inhibits von Willebrand's factor. It's because it's hemolytic uremic syndrome where you have, there's a triad, microangiopathic hemolytic anemia, thrombocytopenia, renal involvement. It could be seen with infections due to the Shiga toxin or E. coli 0157. This is an H7. This is a typo. And then there's a congenital hemolytic uremic syndrome. But due to abnormalities in the alternate complement pathway, I'm not going to talk about that. And then the health syndrome, that's in gynecology. Certain meds, I put these on here, they don't commonly do it, but you should be aware of them. Taclidopyde's not used anymore, mitomycin's rarely used. You should just know what's been reported to cause a thrombotic microangiopathy. These are the labs you're going to get, or pick out LDH, indirect bilirubin. They have to go up and it'll be low. Serum free hemoglobin, needless serum, kind of a hallmark of the LDH and the hemoglobin, and also with tick count. Okay, now what about normochromic normocytic anemia? Okay, this is the big one. This is most common. This could really be anything. Before I start on this, does anybody have any questions? I'm trying to break this down into categories. Any questions at all? Okay, moving on. So you can see this with early iron deficiency, early megaloblastic anemia. You can see with acute blood loss anemia. Of course, it's usually GI bleed. Okay, now the most common cause is anemia chronic disease. Okay, we talked about the mechanism. You can see these things. And you're going to see a lot of anemia chronic disease, especially in the hospital, because these people have chronic diseases. You've impaired iron utilization and decreased erythropoietin response. And the inflammatory cytokines, you have IL-6 stimulating the body to produce hepcidin, which prevents iron from being immobilized from the macrophages and the RAS. And the body is iron, but it's kind of stuck in storage. And this is the most common thing you see. Chronic kidney disease, renal insufficiency, you have hepcidin block, but you also have decreased erythropoietin production. And that's probably the major mechanism in those patients. Okay, now myelodysplastic syndromes. I'm not a hematologist. I'm not going to give you a lecture on this, but these exist and they're common. They're a group of clonal hematopoietic stem cell neoplasms. They have ineffective hematopoiesis, morphologic dysplasia in one of the cell lineages in the marrow, and persistent cytopenias. Okay, so basically they have an anemia, neutropenia, thrombocytopenia or combination, most commonly anemia. Okay, but they have a hypercellular marrow, and they have they have they have a full marrow, but peripheral cytopenia, and more commonly in older people, and more commonly actually presents as anemia. Some of these people could progress to acute myelogenous leukemia, and the diagnosis through certain cytogenic molecular studies. There's a classification scheme. They need a bone marrow, and this is well beyond my level of expertise. But you have to be aware this is not an uncommon cause of chronic non-chronic lymphocytic anemia. And there's a paradox here: peripheral cytopenia, packed marrow, but abnormal cell forms in the marrow, like hyposegmentum poly, some micromagnetic and some of the terms they used to use: refractory anemia with excess blasts, that would be the marrow, refractory anemia with sideroblasts. They've changed. A lot of this is based on chromosomal and genetic testing. Okay, now what about myeloproliferative neoplasms? These are different than myelodysplasia. Sometimes people get them confused. These are a group of clonal hematopoietic stem cell disorders characterized by excessive proliferation of one or more myeloid cell lineages in the marrow, resulting in increased numbers of mature blood cells in the peripheral blood. The classic ones are P. vera, essential thrombocythemia, primary myelofibrosis. With P. vera, clearly you get activation of the JAK-STAT mutation, and you get that. There are other genes like calreticulin and MPO. You also get CMLs in this group also, but that has the BCR-ABL fusion gene. It used to be called the Philadelphia chromosome, and it responds well in targeted therapy. These people could live a long time. They usually, at this point in time, they could live for years and years and die from something else. This stat is over 20 years old, but this has become a different disease. Plasma cell dyscrasias like multiple myeloma could cause anemia. That's the A in CRAB, CRAB, calcium renal anemia, bone. Acute leukemias, obviously, and then myelocytic anemia when the bone marrow gets replaced with abnormal infiltrative elements, leading to bone marrow failure and peripheral cytopenias. But see, there's the list of things like that could cause it. Not common. On the smear, which unfortunately you guys aren't going to get to look at too often, you can see something called the leukoerythroblastic blood picture, nucleated red cells, teardrop cells, habitual myeloid cells. But that's part of the differential. Okay, endocrine causes hypogonadism, a male who is a low testosterone, a lower hemoglobin. Hypothyroidism could cause anemia in a lot of ways. Most common cause is iron deficiency in young women because it causes increased menorrhagia. Adrenal insufficiency could do this, and pituitary problems. And then there's aplastic anemia. Okay, I'm going to show you some pictures here. So these are retics. Retics have what's known as polychromasia. Okay, they don't have central pallor, and they have a purplish blue discoloration. More retics. Okay, these are hypersegmented polys. You could see small pale red. Actually, this is iron deficiency. My mistake. See the central pallor. Normally, the pallor should be about 1/3 the red cell. Okay, and here you see these small cells with central pallor. This is iron deficiency, and if you got to look at purple smears, you recognize this. spherocyte. These are white cells, you can see them with G6PD deficiency. These are ring sideroblasts. I don't think you guys will really be seeing that on the sphere. This is a schistocyte. This is an important thing to recognize. If you're concerned about an microangiopathic hemolytic anemia, you need to see if these are present in peripheral sphere. These are elliptocytes. These are spherocytes. You can see autoimmune hemolytic anemia. And we're done.